This review synthesizes the latest trends, USA focused, on melatonin and heart failure, integrating recent observational data presented at the American Heart Association Scientific Sessions 2025, mechanistic and preclinical evidence, randomized trials and meta-analyses, expert commentary, regulatory context in the United States, and suggested research priorities. It is intended for clinicians, researchers, and informed readers seeking a detailed, evidence-linked overview. Key high-impact sources are cited in text. The full reference list with direct links appears at the end. Introduction: Why this topic matters. Melatonin is an endogenous pineal hormone that regulates circadian rhythms and is widely used as an over-the-counter sleep supplement in the United States. In recent years, melatonin's pleiotropic biological properties, antioxidant, mitochondrial stabilizing, anti-inflammatory, and chronobiotic effects, have attracted interest among cardiology researchers seeking novel adjunctive therapies for heart disease and heart failure specifically. Conversely, a high-profile observational signal presented at the American Heart Association (AHA) Scientific Sessions 2025 raised concern about potential associations between long-term melatonin use and increased incidence of heart failure and related adverse outcomes. This has sparked debate about interpretation, causality, supplement regulation, and clinical guidance. Overview of recent observational findings presented at AHA 2025. At the AHA Scientific Sessions 2025, investigators presented abstract MP2306, Effect of Long-Term Melatonin Supplementation on Incidence of Heart Failure in Patients with Insomnia, analyzing electronic health record data from a large cohort of U.S. adults with chronic insomnia. The study reported that long-term melatonin supplementation, defined by investigators as greater than or equal to 1 year of regular use, was associated with a substantially higher incidence of diagnosed heart failure, more frequent heart failure hospitalizations, and increased all-cause mortality over a 5-year follow-up period. Reported effect sizes and press summaries included near doubling of heart failure incidence, and up to a 3-fold increase in heart failure hospitalizations for long-term melatonin users versus non-users. Interpretive caveats were emphasized by both the AHA press materials and journalists. The analysis is observational, derived from real-world electronic records, and has inherent limitations in proving causality. Media coverage and initial expert reaction. Major U.S. outlets and health journalism platforms covered the AHA abstract imminently, including Washington Post, News Medical, Fox-affiliated local outlets and mainstream national news services. Coverage conveyed both the alarming effect sizes and the cautionary expert reactions that urged against immediate clinical alarm. Experts underscored that insomnia itself and comorbidities often prompting melatonin use are established cardiovascular risk factors, that over-the-counter melatonin exposure is variably documented in medical records, and that confounding by indication and residual confounding could explain a substantial portion of the association. Professional commentaries and Science Media Center summaries reiterated the need for peer review, replication, and more granular exposure assessment before changing clinical guidance. Mechanistic rationale supporting cardioprotection, preclinical research. In contrast to the AHA abstract's associational signal, an extensive mechanistic literature, animal models and cellular studies, supports potential cardioprotective effects of melatonin. These mechanisms fall into several interrelated domains. 1. Antioxidant and free radical scavenging. Melatonin and its metabolites neutralize reactive oxygen species, ROS, reduce lipid peroxidation, and preserve redox-sensitive signaling in cardiomyocytes. 2. Mitochondrial protection. Melatonin modulates mitochondrial dynamics, supports mitochondrial membrane potential, inhibits maladaptive mitophagy, and preserves ADP generation in stressed myocardium. 3. Anti-inflammatory and antifibrotic effects. Melatonin downregulates pro-inflammatory cytokines, attenuates macrophage infiltration in injury models, and reduces fibrotic remodeling after ischemia. 4. Chronobiotic and autonomic modulation. By stabilizing circadian rhythms and sleep architecture, melatonin may indirectly lower sympathetic overactivity and nocturnal blood pressure surges that contribute to cardiovascular stress. These mechanistic data have been summarized in multiple reviews and experimental papers spanning 2018 to 2025, and they underpin the hypothesis that melatonin might reduce ischemia-reperfusion damage and adverse remodeling, pathways intimately relevant to heart failure pathogenesis. Clinical trials showing physiologic or short-term benefits. A number of randomized trials and pilot studies have tested melatonin in cardiovascular settings. These studies are heterogeneous in population: perioperative CAB patients, HFrEF patients, endothelial function trials, dose, timing, preoperative, postoperative, nightly supplementation, and endpoints, biomarkers, imaging, patient-reported outcomes. Notable examples include MARE trial, a randomized trial in heart failure patients with reduced ejection fraction, reported reductions in NT-proBNP and improvements in quality of life measures in melatonin-treated participants compared with placebo. However, the trial was modest in size and short in follow-up. Perioperative cardiac surgery trials. Several small studies reported lower oxidative stress biomarkers and fewer postoperative complications when melatonin was administered around the time of surgery. Meta-analyses and systematic reviews. Pooled analyses have suggested possible beneficial effects on surrogate cardiac biomarkers and symptomatic endpoints, but authors consistently note heterogeneity, risk of bias, and small trial sizes. Reconciling mechanistic promise with observational safety signal. The seeming contradiction between experimentally demonstrated cardioprotective mechanisms and the AHA abstract's association with increased heart failure risk merits careful methodological and biological parsing. Possible explanations include: 1. Confounding by indication. Patients who use melatonin long-term typically do so for chronic insomnia, which itself is associated with increased cardiovascular risk through heightened sympathetic activity, poor metabolic control, and inflammation. If insomnia severity or related psychiatric comorbidities are imperfectly measured or adjusted for in EHR datasets, they can bias estimates toward harm for the melatonin-exposed group. 2. Exposure misclassification and supplement variability. The majority of melatonin use in the U.S. is over-the-counter, OTC, with products that vary in dose, formulation, and purity. EHR records and prescription databases may poorly capture actual consumer use, leading to measurement error. In contrast, clinical trials use defined pharmaceutical-grade melatonin and controlled dosing, which may yield different effects. 3. Dose, response, and chronicity. Short-term melatonin dosing for circadian rhythm correction might have different effects than nightly, high-dose, or long-term consumption. Indeed, mechanistic benefits in animal models often come from specific dosing regimens that may not map to real-world OTC use. 4. Reverse causation and protopathic bias. Individuals with early, subclinical cardiovascular disease or prodromal symptoms disrupting sleep may self-medicate with melatonin. Thus, melatonin use could be a marker of advancing disease rather than its cause. A rigorous reconciliation requires prospective cohort data with detailed sleep phenotyping, medication and supplement capture, and ideally randomized trials in well-defined populations. Quality and limitations of the AHA abstract and EHR analyses. Abstract MP 2306, like most conference abstracts, reports preliminary results that require peer-reviewed publication to fully assess methodology, covariate adjustment, sensitivity analyses, and subgroup findings. Typical EHR-derived analyses face several technical limitations. Incomplete capture of OTC supplement use and dosing in clinical records. Residual confounding by lifestyle factors, smoking, alcohol, diet, sleep disorder severity, and socioeconomic factors that are not fully recorded. Potential coding biases. Diagnosis codes for heart failure can vary by clinician and setting, and hospitalization coding for heart failure events may reflect local practice patterns. Difficulty establishing temporality and duration of exposure with precision, particularly for agents commonly taken without healthcare supervision. Therefore, while the observed associations warrant investigation and thoughtful clinical counseling, they are insufficient to prove harm or to mandate regulatory action without replication and peer review. Regulatory and public health context in the USA. Melatonin is regulated as a dietary supplement in the United States under the Dietary Supplement Health and Education Act, DSHEA, of 1994 rather than as a pharmaceutical. This regulatory status means that manufacturers do not need pre-market FDA approval, and product quality, dosage labeling and contaminant profiles can vary widely. Several analyses over the past decade have documented discrepancies between labeled and actual melatonin content in OTC products, and occasional contamination with novel synthetic compounds. The regulatory landscape complicates interpretation of real-world safety data because the exposure being measured is not necessarily standardized. In response to emerging safety signals, industry groups and some clinicians have discussed voluntary standards, improved labeling, and clinician education about OTC melatonin, while consumer advocates have called for tighter oversight. Clinical implications and interim guidance for U.S. clinicians. Given current evidence, a practical, conservative approach in clinical practice is warranted. 1. For short-term, circadian rhythm correction, jet lag, shift work, or brief episodic insomnia, melatonin at low doses and for limited duration remains reasonable when used under clinician guidance. 2. For chronic insomnia, clinicians should prioritize evidence-based therapies such as cognitive behavioral therapy for insomnia, CBTI, which has durable benefit and no known cardiovascular harms. 3. For patients with established cardiovascular disease or high heart failure risk, clinicians should ask explicitly about OTC melatonin use, document dose and duration, and consider closer monitoring if long-term nightly supplementation is used. 4. Shared decision-making. Discuss the currently unresolved balance of mechanistic promise and observational concern, particularly for patients using nightly melatonin for years. These interim guidance points reflect professional caution rather than definitive mandates, pending higher quality longitudinal and randomized data. Potential biological reasons melatonin could be harmful in certain contexts. While most mechanistic work highlights protective actions, there are plausible scenarios where melatonin could theoretically worsen cardiovascular outcomes, especially in complex human physiology and with non-standardized OTC exposure. Interaction with circadian timing. Inappropriate melatonin timing could disrupt circadian entrainment, leading to misaligned autonomic patterns and metabolic dysregulation in susceptible people. Pharmacologic interactions. Melatonin may interact with commonly used cardiac medications through CYP-mediated pathways or additive sedative effects. Although major adverse pharmacodynamic interactions are uncommon, polypharmacy in heart failure patients raises complexity. Dose-dependent biphasic responses. Some hormones and antioxidants display biphasic dose response curves where low doses are beneficial, but higher or chronic dosing yields paradoxical effects. Contaminants or adulterants in unregulated OTC products that could exert unmeasured cardiovascular toxicity. These hypotheses remain speculative and emphasize the need to understand dose, timing, formulation, and patient-specific susceptibilities. Research priorities emerging from the recent trend. The intersection of promising preclinical data and alarming observational signals yields clear research priorities. 1. Large prospective cohorts with rigorous sleep phenotyping, actigraphy, sleep questionnaires, objective capture of melatonin exposure, self-reports supplemented by purchase records or biochemical markers, and adjudicated cardiovascular outcomes. 2. Randomized controlled trials and well-defined patient groups, e.g., HFrEF patients, high-risk insomnia populations, powered for clinically meaningful endpoints, HF hospitalization, CV mortality, and stratified by dose/timing. 3. Pharmacovigilance and pharmacoepidemiology studies linking retail purchase data, prescription records and EHRs to better characterize OTC exposure patterns. 4. Translational studies examining dose, response curves, timing effects, chronopharmacology, and genetic modifiers of melatonin receptor signaling in humans. 5. Regulatory science investigations into supplement quality and standardization, including independent assays of OTC products sold in the U.S. Such studies would directly reduce the principal sources of uncertainty, confounding, exposure heterogeneity, and lack of randomized efficacy/safety data. How to interpret the evidence as a researcher or clinician. Interpreting this rapidly evolving field requires nuanced weighing of evidence levels. Animal and cellular studies provide strong mechanistic plausibility but limited external validity. Randomized trials to date are small and often assess surrogate or physiologic endpoints. They are hypothesis-generating rather than definitive. Large observational EHR analyses can detect rare or long-term signals but are vulnerable to confounding and exposure misclassification. Therefore, neither preclinical enthusiasm nor observational alarm should singly determine clinical practice. Instead, both should motivate targeted studies and cautious, individualized clinical counseling in the interim. Case scenarios and practical notes. 1. A 68-year-old patient with HFrEF on guideline-directed medical therapy asks about nightly melatonin for insomnia. Recommend CPTI first. If melatonin is considered, use the lowest effective dose for the shortest time and monitor symptoms and BNP/clinical status more closely. 2. A 45-year-old shift worker seeking circadian reset for rotating shifts. Short-term melatonin timed appropriately, pre-sleep, can be beneficial, but counsel against chronic nightly use without reassessment. 3. Patients using multiple OTC supplements should undergo medication reconciliation. Clinicians should document melatonin brand, dose, and frequency due to wide variability in products. Practical points like these preserve patient autonomy while aligning with evidence-based caution. Limitations of the current review. This review synthesizes publicly available data and media coverage up to November 2025 and is not a systematic review. It focuses on U.S. trends and regulatory context. The AHA abstract discussed herein was a keynote observational finding at a major conference but was not a peer-reviewed full-text publication at the time of writing. Readers should consult the final peer-reviewed article once available for definitive methodological details. Finally, while many reference trials and reviews are international, the interpretation emphasizes U.S.-specific supplement regulation and real-world OTC exposure patterns. Conclusion. The current trend in the United States is characterized by tension, a compelling mechanistic and early clinical literature suggesting melatonin may have cardioprotective properties versus a prominent observational signal linking long-term melatonin supplementation with increased incidence of heart failure, hospitalizations, and mortality among adults with insomnia. This tension is scientifically productive. It motivates higher quality cohort studies, randomized trials, improved exposure measurement, and regulatory scrutiny of OTC melatonin products. In clinical practice, the prudent pathway is individualized, cautious counseling, favor non-pharmacologic insomnia treatments for chronic problems, limit long-term nightly melatonin use when possible, document OTC exposures, and monitor patients with cardiovascular risk more closely. Above all, definitive guidance awaits peer-reviewed replication of the AHA finding and randomized trials adequately powered for clinical endpoints.